Well, I am delighted. We are delighted to have Dr. Deepti Gurdasani with us today. Huge fan of all her work. She's been working really hard, really, really hard during this pandemic, talking about clinical epidemiology, which is her background. She also has a medical degree in internal medicine, but really talking about children vaccinations in schools. And that's what we're here to talk about today, really, which is, as we know, this week, we had the much awaited decision from Professor Chris Whitty, our CMO, about whether children get vaccinated or not. He, if you like, slightly did a U-turn from JCVI's decision earlier this month and said that actually we will be vaccinating 12 to 15-year-olds. Not sure if many of you can remember, but at the beginning of the month, we were waiting for JCVI to make that decision, partly because some 14 million children across the world, 14 million teenagers across the world have been vaccinated, but we haven't yet vaccinated children in England. We've been waiting for that decision, but JCVI decided not to give permission for that rollout because they said there was only a marginal benefit to vaccinating healthy 12 to 15-year-olds. But as I've said, Chris Whitty has now recommended that we go ahead based on the fact that it will reduce children's disruption to children's education. But Dr. Gurdasani, I think the public will be quite confused because JCVI are saying there's only a marginal benefit, and actually in their minds it wasn't worth rolling out the vaccination for 12 to 15-year-olds. Professor Chris Whitty said, look, let's go ahead because it will reduce school disruption. Are there no clinical benefits to vaccinating 12 to 15-year-olds?
So I'm really concerned about the messaging. I'm not sure if you can hear me. Yes, you can. Okay. The messaging around the benefits to children and vaccination. I mean, there seems to be a real misunderstanding here about the impacts, first of all, of COVID on children. I mean, we constantly hear that the impacts on children are non-severe, and a lot of that is based on a comparison with adults. And while children probably suffer from severe illness less than adults do, that doesn't mean that the impact on them is in any way insignificant. And it's interesting, the JCVI analysis, which still has not been published, so it's very hard to scrutinize. But while it separated out children who are healthy and children with pre-existing conditions, it did not include one of the major impacts on children, which is long COVID. I mean, there's a very large-scale study that was published recently that suggests that 1 in 7 children, which is a very significant number of children, go on to have persisting symptoms after infection for up to 15 weeks. I mean, that is a lot for one infection to do. And it's quite puzzling that while there has been a lot of focus on theoretical, hypothetical long-term harms from vaccines, which are very, very unlikely to materialize after 3 to 4 months for any vaccine. And even the known risks are very rare and typically mild. There has been almost no consideration at all of even the known risks of the virus, far less the unknown future risks of the virus. Let's just talk about the direct impact on children. So let's remember, first of all, that the exposure to children currently is huge. The choice is not between vaccination and children don't get infected. Right now, if you're not getting vaccinated, you are going to get infected. Just look at the last 2 weeks. If you look at the Public Health England data, in 10 to 19-year-olds, 80,000 children were infected in 2 weeks alone. If you even consider that 5% of those children go on to develop long-term symptoms, that's 4,000 children in 2 weeks alone. And 2,000 of those could have been prevented by vaccination, because another myth is that vaccines don't help with long COVID. The point is vaccines prevent infection, not completely, but to a pretty good extent, by about 50 to 60%. And if they prevent infection, and if you don't get infected, then you can't get long COVID. So those things were not considered by the JCVI. The JCVI felt it was cautious to delay vaccination while we awaited more data on this, which is quite surprising given, as you mentioned, more than 14 million teenagers have been vaccinated across the world, 10 million in the US alone. We are an outlier in Europe. So if you look at France, Italy, Denmark, more than half the adolescents have received at least one dose. And in Italy and France, it's about 50% have been vaccinated fully. And the MHRA, which is a regulatory body which decides whether vaccines are safe or effective, authorized vaccination on 4th of June, since when hundreds of thousands of adolescents have been infected. And for them, this could have prevented long COVID from any hospitalizations. So let's even talk about hospitalizations. 1 in 200 children right now who are cases of COVID, who not infections, but confirmed cases, are getting hospitalized. We are having about 40 hospitalizations in under 18s with COVID every single day. That's not trivial. We've had about 1,000 children hospitalizations every month for the last 3 months. And at the peak, we were having 300 kids hospitalized every week. And we are very likely going to get there. I mean, just looking at the Office for National Statistics data, we have 1 in 37 secondary school age children right now who have infection. That's one kid, probably per 1 or 2 classrooms. And it's likely to rise. Like Christina said, it takes 2 or 3 weeks for these things to gain momentum. And we've really missed that golden opportunity of summer to protect our children, which is why infection is dropping in other groups that have been vaccinated, but rising among children who will now have to face the consequence of infection, which is going to be, sadly, some getting hospitalized, many developing long COVID, and very sadly, some will die. And all of these are preventable. And the message that's sadly being given to parents and all this is that there's no direct impact to your children from vaccination, but they should get vaccinated to reduce anxiety, educational disruption, and impact on others. Whereas the direct benefit to children is extremely clear and very important. And I think this sort of juggling between the JCVI and the CMOs, which is probably meant to sort of save face or whatever, I really, really worry about the impact that's going to have on vaccine hesitancy. And I think it's completely reckless that this opportunity to protect children has been missed.
Thank you. Well, let's go back to the fact that it feels like we've sort of dragged JCVI and the CMO to this position, because I think while there will be many parents out there who will be relieved that their children might be getting the vaccination, will be getting the vaccination now, especially if they're teenagers. And we know that there is strong parental support, of course, for vaccinating teenagers as well as under 11-year-olds. I think a lot of parents will be quite confused about the fact that the CMO, our CMO, and CMOs across the board have only said that children will be receiving 1 dose. What's it about, Deepti? And will that be enough? Will that be enough to reduce educational disruption? Will it be enough to reduce long COVID? Will it be enough to protect grandparents?
So it's really concerning. So again, the 1-dose policy is an outlier. If you look at almost every country across the world, US, Canada, countries in the Middle East, Southeast Asia, almost all countries in Europe, perhaps except Norway and Sweden, are offering 2 doses of vaccines to all children. And while the JCVI seems to be once again concerned about the very rare effect of vaccine-associated myocarditis, which is more common after the 2nd dose, particularly in boys, you need to remember, if you don't give 2 doses, you might reduce those rare and typically mild side effects, but you also reduce the huge benefits from vaccines. And the fact is that we don't really know the effectiveness of 1 dose of vaccines in adolescents or anybody else long term. I mean, what we know with 2 doses and Delta is that immunity wanes over time significantly, and it's very, very unlikely that 1 dose over long periods of time will be sufficient in preventing infection, which is what you need to do to prevent things like long COVID, which occurs, in healthy young children. So it's very unclear to me what sort of analysis of risk benefit or evidence this is based on, because there's certainly no evidence that we have on a single dose of vaccine, the protection it will be able to provide and for how long. But the benefit of 2 doses is very, very clear and has been recapitulated, by the CDC and countries all over the world that frankly have vaccinated millions of children with 2 doses. And we are seeing the impacts of that. In the US, for example, it's very clear that children who are vaccinated have about 10 times lower risk of hospitalization than those who are unvaccinated. And we need to remember that actually, we talk about vaccine-associated myocarditis, but COVID itself causes damage to multiple organs in the body, even in people with mild symptoms. I mean, we see this even in young adults who, for example, develop thinning of the brain after 6 months. We see effects on their kidneys with reduction in kidney function over 5 to 6 months after the acute infection. It's very likely that this also happens in children, but it's not really been studied much. And if you want to prevent these long-term effects, essentially we can't expose children to infection. And we are doing that by putting them into crowded classrooms with almost no mitigations in place and sadly unvaccinated, when the global evidence is telling us that that is completely unsafe. And we know that the impact of COVID on the heart, kidney, lung, and brain are for the longer term.
Thank you. So actually, you partially answered this question, but I was going to ask you, given, as Professor Katsarakis has mentioned, we're dealing with a different variant here, the Delta variant, which has really changed the game on us. Given that context, it's not just a question of is one dose is enough. Do you think just having vaccines is enough? Can we just have vaccines and remove all other mitigations in schools, and will teenagers be fine? And will all children be fine?
No, that's very unlikely. In fact, we're seeing that even in places where children are being vaccinated. I mean, certainly it helps, but you need multi-layered mitigations. We need to remember that children have had the highest infection rates in this pandemic post-Delta in, I would say, most countries across the world. I mean, and we're seeing the same patterns in England and Scotland here. And even with multi-layered mitigations, it's very, very hard to control Delta in environments that are crowded, where lots of people come together. And vaccines don't confer 100% protection. They will definitely help. They reduce transmission, but we need other mitigations like masks, ventilation, that have been completely ignored largely in England. We need bubbles. We need good contact tracing in schools. I think it's incredible that if I get COVID today, my daughter can go into a classroom being exposed to me day in and day out and infect other people. Similarly, if there's a case in a classroom sitting right next to her, she won't even be informed. And we're seeing huge outbreaks in schools as a result at the moment. So vaccines are definitely part of the whole picture, but in of themselves, they're not going to be sufficient to be able to keep schools open. And the people who talk about the huge impacts of educational disruption and school closures should be actively advocating for mitigations in schools and for vaccination of children to make it possible to keep schools open.
Thank you. Now, I have got a cue to move on, but I do have one very, very last question. If the chair would allow, Chair Pillay, Professor Pillay, please, I have one tiny quick question, which was on everybody's minds, which is, what about if your children are younger than age 12? What about the 5 to 11-year-olds? Should we, so that we don't, so that JCVI doesn't get stunned by this issue when it occurs, should we be vaccinating 5 to 11-year-olds? And if you don't mind, Dr. Gurdasani, if you could just give us a quick answer for that, please.
Yeah, sure. So the AAP, which is the American Academy of Pediatrics, has been pushing very hard for that to happen, because sadly they're seeing a lot of severe illness in that group because of very high rates of infection. And I believe that Pfizer is submitting a report to regulators from the very recent trials in that age group and are hoping to get approval quickly. I know many countries are very keen to start rolling out the vaccine to that age group. Israel, in fact, has already started rolling out the vaccine to vulnerable members of that age group because they were concerned about the potential severity of disease given the high rates that they're seeing. I honestly hope that we don't have to go through the same process of delay and dither while thousands of children get ill once again. And I hope that the JCVI this time will take a more rational and evidence-based approach.
Thank you. Thank you very much.